Hello, good morning or good evening, everyone. My name is Dr. Naweed Alzaman. Thank you for the organizing and scientific committee of DAR International Alliance Conference for inviting me to present today. Thank you, Mr. Chairman, for the introduction. My talk today will be about fasting in Ramadan in adults with type 1 diabetes and if they are all at high risk. I work as an adult endocrinologist at Al Madina Al Munawwara. I'm an assistant professor at College of Medicine at Taiba University. To begin with, we understand that most of our type 1 diabetic patients are considered to be at least from moderate to high risk. Uh, Having type 1 diabetes itself gives them a risk score of 1. Having type 1 diabetes along with the regimen of insulin they are using gives them a score of 2.5. So that by itself, it's like a 3.5 score, which considered to be a moderate risk for fasting. That's taking into consideration if those patients are not having any hypoglycemic episodes or what's their A1C look like, and if they have had any acute complications in the last 1 year. So if the patients have a score 0 to 3, they are considered to be a low risk. And if patients are scoring from 3.5 to 6, they are at moderate risk. And if they are more than 6, they are considered to be a high risk according to the Diabetes and Ramadan Practical Guidelines published in 2022. So based on what I told you, most of our type 1 diabetic patients, uh, according to their condition, will be considered as either moderate or high risk. And in moderate risk patient, fasting safety is uncertain. And fasting is preferred, but if a patient choose to fast, patient may choose not to fast if they are concerned about their health and after consulting the doctor and taking into the account the full medical circumstances in patient's own previous experience. And if the patient does fast, they must follow the medical recommendations, including the regular blood glucose monitoring. And these are the recommendations that have been agreed upon between the medical and religious sections. For those who are at high risk, of course, as doctors, we tell them that the fasting is probably unsafe, and we advise them against fasting in coordination with the religious recommendation as well. And that was based on multiple studies with using the CGM data uh, that has shown that patients with type 1 diabetes actually, the fasting was associated with potentially unfavorable changes in the blood glucose or in the glucose metrics as per CGM. As you can see in this very nice study uh, done by the group in UAE, you can see that the green line, how the fluctuation in the glucose happens, especially before iftar and after iftar. And you can compare that to the red line that was pre-Ramadan with much less fluctuation. And also another study has, and other multiple studies has shown that at least, anywhere between 25 to 30% of patients are actually prone to have a severe hypoglycemia during fasting in Ramadan. And because of that, the scoring system was helpful to define which group of those patients will be able to fast and which group is not. During COVID-19, we did a survey, and that was a dark global survey to determine the impact of COVID-19 pandemic on intention to fast and the outcomes of fasting. People with type 1 diabetes were surveyed in 13 countries during 10 weeks between June and August of 2020. And at least when we surveyed those patients and after Ramadan, we found that at least 27% fasted for full 30 days. 45% fasted only for 22 to 29 days, and they broke their fast because of the diabetes-related illness. 28% fasted only for 3 weeks or less because of the diabetes-related illness. Then we defined those group of patients who intended to fast. That's more than 70% of type 1 who intended to fast with a definition of rate fasting countries. And high rate fasting countries included around 817 people with type 1 diabetes, out of which 89% intended to fast, and there had their mean A1C of 8.75 with average duration of diabetes 8.7. And as you can see on the right side of my screen, majority of those patients came from Saudi Arabia, but along from Saudi Arabia, Pakistan and Malaysia also contributed to those high fasting rate countries. And when they were asked about their decision to fast Ramadan during the COVID-19, 96% of them answered by yes. And very interestingly, and that was reassuring, that at least 63% of those who decided to fast, uh, they said that they have received specific education for Ramadan fasting. But still, 37% of those who decided to fast during COVID-19, despite being high risk, did not receive any education before Ramadan. And then we asked them how many days did they manage to fast if once they decided to fast, and if they have, broke their fast because of diabetes related illness, if so, for how many days, and what happened in terms of the hypo and hyperglycemia. So at least 25% of them managed to fast for 30 days, and 30% or 50% of them managed to fast between 22 to 29 days. And majority of those patients, or at least two-thirds of them, said that they had to break their fast despite their decision to fast because of the diabetes-related illness. And most of them had to break their fast at least between 1 to 7 days. And in terms of the hypoglycemia, at least was average for 8 days over the 30 days of Ramadan. And, it was, kind of divided when the hypoglycemia mostly happened, and that was different in between different countries. 33%, said that their hypoglycemia was between suhoor and 9 a.m., while 24% said their hypoglycemia was between 3 p.m. and Maghrib time. What about the hyperglycemia when their glucose values were more than 300 milligram per deciliter? At least 46% reported hyperglycemia during Ramadan on average of 8 days, and 32% during fasting hours. This is really amazing. As we can see that, if in this slide I'm presenting to you that 88% of those patients who experienced hypo, they decided to break their fast, while 74% of those who experienced hyper, where their blood sugar was more than 300, they decided to continue fasting without breaking. And this comes back to the way those patients were educated. Maybe they were told only to break their fast if they feel hypo, but they were not given any specific instructions when they were hyper. Fortunately, most of those patients were able to manage these acute situations at home. Only 3% of those required emergency room visit or admission to the hospital, either related to hyper or hypoglycemia. So despite that, what I have shown you, and despite their high risk score, many patients will choose to fast. And we decided to compare the fasting of Ramadan in patients with type 1 diabetes in Saudi Arabia versus other countries during the COVID-19. And as you can see, there was a major difference in terms of the percentage of patients who decided to fast. At least 90% of those with type 1 in Saudi Arabia decided to fast versus 53% in other countries. And there was also other differences in terms of the numbers of days broken, as well as their age. Very slight difference in terms of the A1C, as well as the comorbidities. But what's more important, let's look at the similarities, even though they decided to fast. Look at the similarities between Saudi Arabia versus the other countries. They all had a baseline A1C that is above target. Majority of them, of course, were on MDI. Majority were able to fast more than 15 days. Around 27% were able to fast the 30 days, and around 55% of them received Ramadan education. What was the difference is really the intention to fast was much higher in our region. The incidence of hypos and hypers were higher. The frequency of SMBG monitoring was higher in Saudi Arabia. The timing of hypo was different, and the actions taken by patients were different. So patients in Saudi Arabia versus the other countries were monitoring their blood glucose more frequently. They were having hypos more after suhoor compared to the other countries, probably related to the type of meal they are having at suhoor. And they actually managed to decrease their dose of insulin more frequently compared to the other countries. So as you can see in this slide on the left side, you can see that those patients who had hypos, they said that they reduced the dose of insulin, and they answered that more compared to the groups from other countries. And also, the methods of diabetes education was more significantly in the favor of those patients in Saudi Arabia who received education through online or through application regarding the managing diabetes in Ramadan. So, are there any possible explanation for this high rate of fasting despite the risk, which needs further studies to explore? Is it really the availability of resources and education in our region that push those patients to fast? Is it really the availability of CGM that we are really thrilled that all of our type 1 diabetic patients have access to CGMs? It's really the reason why we do have patients are more intended to fast. Is it the other way around? Is it really the lack of understanding of the physiological changes that can happen with the fasting? Is it really the social factors, the school, the community? Is it is it the factor of pressure by family and friends? Is it the fear of being stigmatized if they did not fast? Is it the lack of education? Is it lack of understanding of clear religious fatwa regarding their condition? So it can be any of those that really pushing those patients to fast. And when patients decide to fast, or the healthcare professional is pushing them to fast, and really how to overcome this is really to do a proper selection, do an education, use the available resources, address the behavioral challenges, and learn from the past experiences. So what we have learned that SMBG frequency should increase after suhoor, especially in our group of patients and before Maghrib in high fasting rate countries. Hyperglycemia should be addressed as an acute complication and should require immediate action, and those adjustments should not be ignored by patients during fasting. Education is a priority that needs to be started months before Ramadan, especially in patients living in high fasting rate countries, as we saw that more than one-third of those patients are still fasting without breaking their fast despite having hypo and hyperglycemic episodes. Proper risk assessment and selection in order to achieve safe fasting is critical. Individualization is the key for safe decision based on the current data. Thank you for your listening.